Okay, so welcome back to this next video in which we are discussing rheumatoid arthritis. Okay, so we've now discussed that the first line treatment for rheumatoid arthritis is a combination therapy of an NSAID with a DMARD. Okay, the NSAID will reduce inflammation of the joints and also reduce pain associated with the rheumatoid arthritis joints. Okay, and the DMARD will better stop the pathological process, basically. Okay, so we've discussed that the major first-line DMARD that's used is Methotrexate. Okay, if you were to quote one drug that's used to treat rheumatoid arthritis, it would be Methotrexate. Okay, which is an immunosuppressant, a very powerful immunosuppressant that works by stopping cell division. Okay, thus it stops more T cells and more B cells being produced, and then all you have to do is wait for the ones that you've got to gradually fade away. Okay, they'll gradually be removed, and you won't get any more, and then eventually the autoimmune response will subside, and then you can stop the inflammatory response in the joints, and you're not going to reverse the joint damage that you've already got, but at least it won't get any worse. Okay, right, so we're now going to discuss more DMARDs which work by having an immunosuppressive action. Okay, so the first drug that I want to talk about is a drug called Sapphire Print, and this basically, how it works is almost identical to Methotrexate. Very different target, but how it actually prevents further damage to the joint is pretty much the same story. Okay, so Sapphire Print is actually a prodrug. Okay, it is metabolized in the body to a drug called mercaptopurine. Okay, and this is also a very powerful immunosuppressive drug. Okay, and it works in the same way as Methotrexate in that it also prevents cell division, and it does so by blocking the synthesis of nucleotides that you need in order to produce DNA and RNA. Okay, in the case of mercaptopurine, it just stops the synthesis of purines. Okay, so purines are going to stop being made. So adenine and guanine are the purines. Okay, and you're not going to make any more adenine and guanine nucleotides, and that means that you're going to be able to stop DNA synthesis and RNA synthesis. And of course, just like in the case of Methotrexate, that's going to stop cell division because you're now not going to be able to copy your DNA, you're not going to be able to make more proteins. Okay, and stopping cell division will have an immunosuppressive action for exactly the same reason as Methotrexate had an immunosuppressive action. Okay, if you can't have cell division, then you can't amplify your numbers of B cells, and you can't amplify your numbers of T cells. Okay, right. So azathioprine, working through the active drug mercaptopurine, has a very different target to Methotrexate. Okay, so mercaptopurine doesn't inhibit the dihydrofolate reductase. It blocks purine synthesis by other targets, okay, which we're not going to go into. But the underlying reason for why azathioprine is effective in treating rheumatoid arthritis is the same as for Methotrexate. Okay, right, now what we're going to discuss is other examples of immunosuppressants which work in very different ways to azathioprine and Methotrexate. Azathioprine and Methotrexate work by stopping cell division, full stop. Okay, we're now going to see some more subtle immunosuppressants that work by blocking T cell activation. Okay, and thereby blocking the adaptive immune response. But they don't work merely by stopping cell division. Okay, they work more selectively by stopping the pathway which leads to the activation of T cells. Okay, so let's go back and revise how T cells are activated. So remember, T cell activation involves these three signals. You firstly have to get signal 1, which is generated when the T cell receptor and the CD4 have bound to an MHC class II molecule with a peptide fragment presented on it. Okay, and you then need signal 2, which is given when a CD28 molecule binds to a co-stimulatory molecule on the surface of our antigen-presenting cell. Okay, now signal 1 and signal 2 we then discussed causes an alteration in gene expression within that T cell, where the T cell starts increasing its expression of interleukin-2 and also the interleukin-2 receptor alpha component. Okay, and then the interleukin-2 that you've secreted stimulates the interleukin-2 receptor on the surface of the T cell, and that gives signal 3. Basically, the drugs that we're now going to study, which are Cyclosporine and Tacrolimus, work by blocking signal 1 and signal 2 from actually causing the increased synthesis of interleukin-2 and interleukin-2 receptor alpha. So we now need to study how signal 1 and signal 2 actually lead to an increase in the synthesis of interleukin-2 and interleukin-2 receptor alpha component in more detail, so we can understand how these drugs block that pathway. Okay, right, so let's say then that we've got signal 1 coming in from our CD4 molecule and from our T cell receptor, and we've now got signal 2 coming in from our CD28 molecule. Okay, what do these cause? Well, through pathways that I'm just going to summarize down to arrows, these lead to a rise in intracellular calcium level. Okay, so we're not going to discuss the pathways by which the signal 1 and signal 2 actually lead to a rise in intracellular calcium. Okay, they're horrendous pathways. Okay, so we're just going to summarize them down to arrows. We don't need them anyway. The bit that we're going to need comes after the rise in intracellular calcium. Okay, right, so what then does a rise in intracellular calcium produce? Well, basically, when calcium goes up in the cytoplasm of the cell, it can have effects on a huge number of different targets in the cell, and one of the major ways that it affects proteins is by first binding to a protein called Calmodulin, and then the Calmodulin protein with calcium bound to it then binds to other proteins and affects their function. Okay, so to avoid every protein that needs to be regulated by calcium actually having to have a calcium binding domain of its own, you have this other protein called Calmodulin, which can bind the calcium and then can bind to other proteins. So other proteins just need to have a binding domain for Calmodulin rather than calcium. Okay, so let me just discuss Calmodulin in a little bit more detail. Okay, so Calmodulin exists in these two states. One state where it doesn't have calcium bound to it, and in the state when it doesn't have calcium bound to it, it's called apocalmodulin. And by the way, Calmodulin is often abbreviated down to capital C, lowercase a, uppercase M, like so. So this is the abbreviation for Calmodulin. Okay, so let me draw a picture of apocalmodulin here. So apocalmodulin has two lobes, okay, what's known as the M lobe here, okay, and the C lobe, okay, and both of these lobes have two binding sites for calcium. So here are the two calcium binding sites on the N lobe, and here are the two calcium binding sites on the C lobe, okay, and the two lobes are connected by a linker here. Okay, right, so that's a basic picture of the structure of apocalmodulin. These two lobes with this linker between them, and at the moment there's no calcium in either of those binding sites on either of the two lobes. Okay, now, notice some structural features of what I've shown you here. The lobes of apocalmodulin are sort of hunched back over towards one another, so it's sort of as though it's bent round like so. It's got a curvature to it, and the N lobe and the C lobe are sort of curved back towards one another. Okay, this is going to change when we go from apocalmodulin to a calcium-calmodulin complex. Okay, so when calcium ions bind to those binding sites on the lobes of the calmodulin molecule, then you get what's known as a calcium-calmodulin complex. Okay, and the calmodulin molecule changes its structure vastly. Okay, so what happens is the whole thing becomes straighter. The lobes of the calmodulin move outwards, okay, and it no longer has this hunched over shape. In contrast to the whole molecule becoming straighter, the linker between the two lobes goes from being a linear stretch of polypeptide to being in an alpha helical shape, basically, to being folded up like a spring. Okay, so like so. So, this is when you have calcium bound in those 4 binding sites here. So I'll draw the calcium now. So these orange dots can now represent the calcium molecules in those calcium binding sites. So this is what calcium calmodulin complexes look like. So basically, when calcium goes up in the cytoplasm of the cell, calcium molecules can bind to calmodulin proteins, convert them into these calcium calmodulin complexes, okay, and now the calcium calmodulin complexes can then bind to other proteins and affect their behavior, okay. So the calcium is going to cause the production of calcium calmodulin complexes. What are the calcium calmodulin complexes now going to do within our T cell cytoplasm? Well, the calcium calmodulin complexes are going to now activate a phosphatase enzyme called calcineurin. Okay, so I'll just put this down here. So calcineurin is a serine threonine phosphatase. Okay, it removes phosphate groups from serine and threonine residues of proteins, and for short it's abbreviated to CAN, and you have capital C and then capital N and a lowercase a in between. Okay, right. So I'll draw calcineurin in the sort of typical way for showing an enzyme. Okay, so like so. Here's its active site at the center there. Okay, and then we'll put calcineurin inside. Right, so as I was saying, it is a serine threonine phosphatase, and I'll abbreviate serine down to SER and threonine down to THR. Okay, and this means that it's going to remove phosphate groups from serine and threonine residues within proteins. Okay, now, what's going to happen is calcineurin is not usually active. Okay, it's floating around in the cytoplasm, but it's not usually doing anything. Calcium calmodulin complexes are capable of activating calcineurin. Okay, so what's now going to happen is calcium calmodulin complexes are going to bind to calcineurin enzymes in the cytoplasm. Okay, and I might even show this. So here is our calcium calmodulin complex now bound to our calcineurin. Okay, and it's now going to activate that calcineurin. So the calcineurin is now activated. So I have some sparks coming off it. Okay, and now what it's going to go and do is it's going to remove phosphate groups that are attached on serine and threonine residues on a certain protein that's located in the cytoplasm. Okay, so this protein is really important. Okay, there is a protein that is currently in the cytoplasm, but which is going to now translocate into the nucleus once it's had some phosphate groups removed. Okay, and for short, this is called NFAT, and this stands for the nuclear factor, that's the NF, and then there's OV, and the AT is activated T cells. Okay, so NFAT stands for the nuclear factor of activated T cells. Okay, now, the nuclear factor of activated T cells is a transcription factor. Okay, it can bind to DNA and change gene expression. Okay, and when it goes into the nucleus, it will change the gene expression of the interleukin 2 gene and the interleukin 2 receptor alpha gene. Okay, so it's what drives the expression of interleukin 2 and interleukin 2 receptor alpha. However, to do that, it has to be in the nucleus. It's useless it being in the cytoplasm. Okay, and at present, in the inactive T cell, NFAT is kept in the cytoplasm by a whole bunch of phosphate groups that are attached to it. Okay, so when it's got phosphate groups attached to serine and threonine residues, it is kept within the cytoplasm. Okay, I've just put an arbitrary number of phosphate groups there. I don't mean to imply that it's exactly 3 that NFAT has. I don't know what the exact number of phosphate groups that it has attached onto it. All I know is it's more than 1. Okay, right. So NFAT has lots of phosphate groups on serine and threonine residues, and these phosphate groups keep it in the cytoplasm. So whilst it's got these here, it can't go into the nucleus. It's kept in the cytoplasm, and in the cytoplasm it doesn't do anything. It's no use in the cytoplasm. Okay, so in our inactive T cell, NFAT's in the cytoplasm, and you're not producing interleukin-2 or interleukin-2 receptor alpha. When you get signal 1 and signal 2, that causes a rise in intracellular calcium. You get calcium calmodulin complexes forming. You activate calcineurin, which is a serine threonine phosphatase, and you can tell what's going to happen now. It's going to go over to the nuclear factor of activated T cells and chop off those phosphate groups that are on serine and threonine residues of the NFAT. Then the NFAT is no longer going to be held within the cytoplasm. It's now going to go into the nucleus. Okay, and what's it going to do? It's going to change gene expression like transcription factors do. It will increase the expression of interleukin-2 and increase also the expression of the interleukin-2 receptor alpha component. Okay, and then that's how you can progress on to signal 3. Okay, so the immunosuppressants that we are about to see are going to work. They're going to block the adaptive immune response by blocking the activation of T cells like so. Okay, right. So how are these drugs going to work? Well, let me tell you the names of these drugs, and then we'll have a look at how they actually work. So the two drugs that work to block this pathway are called Cyclosporine and also Tacrolimus, okay, and they're both clinically used immunosuppressant drugs, which are counted as disease-modifying anti-rheumatic drugs when they're used to treat rheumatoid arthritis. Okay, they have applications stemming beyond rheumatoid arthritis. Okay, they're used in organ transplants and things like that as well to prevent rejection. Okay, just like Methotrexate had uses beyond rheumatoid arthritis, it's also a powerful anti-cancer drug. Okay, right. So how do these drugs work? And in fact, I've got one more thing to tell you just before we move on to how they work. Tacrolimus is also called FK506. So Tacrolimus was a really important experimental drug long before it was ever used clinically. And when a drug is just an experimental drug and not actually used clinically, often it doesn't have a proper name. Instead, it has a code name like so. And Tacrolimus's code name was FK506. And because it's such a famous drug, because it was so important experimentally, you often will hear people still call it FK506. Okay? Right, and that's going to be important when we want to name one of the proteins it's going to bind to. Okay, so let's begin with how cyclosporine prevents T-cell activation. Okay, so basically cyclosporine binds to a protein within the cytoplasm of cells called cyclophilin. Okay, so I'll draw this here. So this can represent our drug, cyclosporine, here. Okay, and this can represent the protein it's going to bind to, and this is cyclophilin. Okay, so once the cyclosporine is in the cell, it binds to a protein called cyclophilin, and this complex of cyclosporine with cyclophilin is then going to actually bind to calcineurin enzymes. Okay, so this now goes and binds to the calcineurin enzyme and inhibits it. Okay, and it inhibits it so strongly that even if there's a calcium signal within the T cell and you get calcium calmodulin complexes being formed, those calcium calmodulin complexes are not going to be able to activate the calcineurin. Okay, so these cyclosporine cyclophilin complexes block the activation of calcineurin, and therefore they block the removal of the phosphate groups from the nuclear factor of activated T cells. Hence, they block the effect of signal 1 and signal 2 inside the T cell, and they block the T cell going on to get signal 3, which, remember, requires the expression of interleukin-2 and interleukin-2 receptor alpha. Okay, so that's how cyclosporine works. Tacrolimus does almost exactly the same thing, i.e. it binds to a protein in the cytoplasm of the cell, and that complex then inhibits calcineurin and stops it from being activated by the calcium Calmodulin complexes. However, it binds to a different protein. Okay, so tacrolimus, we can use the exact same picture. This orange molecule is now the tacrolimus, and instead of it being this protein called cyclophilin, the protein tacrolimus binds to is something called FKBP12. And this is why it's important to know that tacrolimus is also called FK506. So basically, FKBP stands for FK506, and then the BP is for binding protein, and then it's FK506 binding protein 12. Okay, so there are absolutely loads of proteins in cell biology that are called FKBP, okay, and they're all named because they were found to be proteins that FK506, now called tacrolimus, could bind to. Okay, so tacrolimus binds to FKBP12. That complex then binds to the calcineurin and blocks the calcineurin being activated by calcium Calmodulin complexes. So it doesn't become active, it doesn't remove the phosphate groups from the nuclear factor of activated T cells. You do not get signal free, you do not get the activation of your T cells. Okay, so you prevent the activation of T cells. T cells are required for the activation of B cells, hence you block the activation of the entire adaptive immune response. Okay, this means that once again you block the generation of more adaptive immune system cells, okay, because you need to activate the adaptive immune system every time you want to produce more cells, basically, okay. So if you give this drug, you're going to stop any more activation of the adaptive immune system. So all you now need to wait for is for the cells that you've already got again to clear, and then you're not going to be able to activate any more adaptive immune responses, and so you will gradually lose adaptive immune cells from the subintima, and therefore the autoimmune disease will gradually clear, and then you'll stop the chronic inflammation. So again, cyclosporine and tacrolimus are classified as disease-modifying anti-rheumatic drugs. Okay, and again, they work by having very powerful immunosuppressive actions. But these immunosuppressive actions are very different from the immunosuppressive actions of Sapphire Print and Methotrexate. Okay. Right, so now what we're going to do is continue on with our discussion of more disease-modifying anti-rheumatic drugs. Okay, and the ones that we're going to look at now just get a little bit strange, okay? There doesn't seem to be that much connection between them. There's certainly not any connection between them chemically, okay? And their mechanisms are very poorly understood. Okay, so we're going to now start by discussing penicillamine. We're then going to go on to the gold compounds, the anti-malarial drugs, and then finally sulfasalazine. Okay, right. So let's start by discussing penicillamine. Okay, so penicillamine is a breakdown product of penicillin antibiotics. Okay, and its structure is actually very similar to the amino acid cysteine. And in fact, another name for penicillamine is to call it dimethylcysteine. Okay, so let me just show you the structure of dimethylcysteine. So this time I will be drawing the amino acid out as though it's actually a free amino acid, because this time it is going to be a free amino acid. So here's the amino group, here's the alpha carbon, here's the carboxylic acid group, so that's the core amino acid structure. And now the R group of dimethylcysteine is like cysteine, so you have a carbon and then a phyl group coming off it, so a sulfur bound to a hydrogen, but then instead of two hydrogens coming off this carbon here, instead you have two methyl groups, and that's why it's going to be dimethylcysteine. Okay, so this is dimethylcysteine, which is penicillamine. So this is the structure of penicillamine. They're the same molecule, basically. This is just another name for penicillamine that doesn't give away that it's a breakdown product of penicillin. Okay, right. So our understanding of why this drug is effective in treating rheumatoid arthritis, and it is effective in treating rheumatoid arthritis, is very poorly understood. Okay. However, we think that the way that it works is that it blocks the synthesis of interleukin-1. That's what we found so far. We think, so this is speculative, blocks interleukin-1 synthesis. Okay, so remember, in our understanding of the pathogenesis of rheumatoid arthritis, you originally get the infiltration of the adaptive immune system cells. Okay, they drive the chronic inflammatory response, and the way they do that is by activating the synovial macrophages to release those pro-inflammatory molecules, and one of the utterly key ones, one of the primary cytokines, was interleukin-1 along with tumor necrosis factor alpha. And interleukin-1 was all the time there. It was one of the key drivers of the chronic inflammation. It was one of the drivers of the changes to the synovial membrane, the hyperplasia of the synovial intima, the pannus. It was a driver of the breakdown of the hyaline cartilage. It was also a driver of the expression of rank ligand and therefore osteoclast differentiation and production, and therefore bone erosion. So interleukin-1 was all the time there after you had the adaptive immune cell infiltrate. Okay, so that would explain why penicillamine has a very powerful anti-inflammatory effect in rheumatoid arthritis, okay, and why it reduces the gradual damage to the joint that occurs in rheumatoid arthritis. Okay, but again, I'll state it again, that our understanding of the mechanism of these DMARDs that I'm about to discuss, of which penicillin is one of them, is very, very poor, basically. So we think it blocks interleukin-1. That's all we know about how it works at present. Okay, right, so I think we'll have a break there, and in the next video we'll continue discussing these bizarre disease-modifying anti-rheumatic drugs. We'll go into the gold compounds, the antimalarial drugs, and sulfasalazine. Then we'll move off the DMARDs and go onto the glucocorticoids, and then finally onto the biopharmaceuticals.